Hi, welcome back to IU Radiology Case of the Day. This is Tim Tsai, and I am a fourth-year resident at the Indiana University School of Medicine. Today, we've got an interesting musculoskeletal case. I'd like to give a shout out and thanks to Dr. Meritz for his help, and of course to Dr. Kuntz for organizing the entire Case of the Day initiative. I'd like to take a moment to emphasize that all the content in this presentation has been fully de-identified to protect patient privacy. For the history on this case, we have an 18-year-old with left knee pain. Have a look at the images. We have a sagittal proton density and a sagittal T2 image through the knee. Okay, so what are the findings? What's your differential for this case? And what is your diagnosis? Let's go through the images and the findings. We see that this patient has undergone an ACL repair. In the intercondylar notch, anterior to the ACL graft, we have a rounded, heterogeneous, intermediate to low signal lesion. This is a good case of a cyclops lesion. Cyclops lesions refer to a focal anterior knee arthrofibrosis. Arthrofibrosis is the excessive accumulation of intra-articular scar tissue which can result in pain, stiffness, and swelling. While arthrofibrosis can occur in a more generalized form, the focal fibroproliferation of cyclops lesion is the most common manifestation. Cyclops lesions occur in about 1 to 10% of patients following ACL repair, although there are a few rare cases occurring without ACL repair. This may be reflective of a shared pathophysiologic etiology of microtrauma. When patients have a cyclops lesion, they may or may not be able to fully extend their knee due to a rubbery endpoint. There may even be an accompanying auditory and palpable pop, click, or clunk on extension. After manipulation of the knee into full extension, the knee may then rebound, as would be expected in what is essentially a rubber ball caught in a hinge. I say that patients may or may not be symptomatic, as on histology there are hard, true lesions containing osseous or cartilaginous tissue, as well as soft cyclopoid scars with easily compressible fibroproliferative tissue. Cyclops lesions are seen on MRI as intermediate to low signal, rounded, heterogeneous lesions in the intercondylar notch anterior to the ACL graft. The differential includes focal PVNS, synovial chondromatosis, and loose bodies. Focal PVNS can be difficult to differentiate, as cyclops lesions may also have varying hemosiderin deposition. A history of ACL repair and the patient experiencing cyclops syndrome with limited knee extension favor cyclops lesions. Synovial chondromatosis and loose bodies can also be located in the anterior intercondylar notch, but knowledge of the patient history and careful scrutiny of the images can readily distinguish the entities from one another. Cyclops lesions are treated with arthroscopic resection, as physical therapy has not shown to help. For further reading on complications of ACL repair, I'd like to recommend this paper. To sum it all up, cyclops lesions refer to focal anterior knee arthrofibrosis, usually following ACL repair. It appears as a rounded, heterogeneous, intermediate to low signal lesion anterior to the ACL in the intercondylar notch and above the roof of the tibial tunnel. Pitfalls include differentiation from focal PVNS, in which the patient history of ACL repair and cyclops syndrome would be strong differentiators, as well as synovial chondromatosis and joint bodies. Rare instances of cyclops lesions occurring without a history of ACL repair may be reflective of a shared pathophysiologic origin. So as always, thanks for tuning in to the IU Radiology Case of the Day. You can follow along on Twitter at NAKuntz, and you can check out our complete collection of Case of the Day materials at the link below. Thanks so much and have a great day.